By the end of this lesson, you should be able to describe at least 3 psychiatric disorders or examples of acute behavioral crisis. You should be able to discuss specific strategies for overcoming barriers to communication and assessment of patients in the midst of a behavioral crisis or those who are experiencing acute psychosis. Now, today when I refer to the term psychotic, I want to make sure that everybody's clear on the definition there. The actual definition is out of touch with reality, meaning they are experiencing things that are not real, whether that be hallucinations or having delusional beliefs that are false. Anyway, those type of things go along with psychosis, as well as to varying extents, some unpredictability that we need to be aware of, and we'll discuss that more later on. You should be able to give examples of how inappropriate use of physical or chemical restraint has resulted in litigation or the injury and even the death of patients and providers. Those stories don't often make national news, but trust me when I say that I've been doing research on this topic for 2 to 3 years now, and these sorts of things happen a whole lot more frequently than you might otherwise believe. And then clearly distinguish the roles of EMS and fire from those of law enforcement. This is absolutely essential when it comes to restraining aggressive, intoxicated, or otherwise involuntary persons. And then finally, list at least 5 ways that you can improve the safety and the effectiveness of your patient restraint skills. We all have our little nuances, little behaviors that may be a little peculiar. You may have heard someone say, or you may have said this yourself, that you're a little OCD, and referring to obsessive compulsive disorder. The tendency for some folks is when they are walking away from their vehicle in a parking lot, they will hit the lock button on their key fob 3 or 4 times before they get 20 yards away from the car. If that describes you, you can relax. That does not mean that you have obsessive compulsive disorder. It can be a true psychiatric illness. The symptoms must significantly impair your ability to function in daily life. What do I mean by that? I mean, it should interfere with your ability to have a job, to have a normal social life, and perhaps even to provide for your basic needs like food, shelter, clothing, and your health care. Now, one thing that we need to always be cognizant about is that a lot of psychiatric illnesses can appear in much the same presentation that actual metabolic and structural emergencies in the brain can mimic. So make sure that any abnormal behavior that you encounter in patients, you need to rule out the possibility that there is something else going on with the brain, because any of these acute alterations in the brain, you have to make the assumption that it's something that could potentially be life-threatening. And this could be anything from a stroke to a traumatic brain injury, seizures, especially, I don't know if you've ever encountered one of these patients that's in the postictal phase, where they are abnormally aggressive from their baseline behavior. That's actually not all that uncommon. And then, of course, things like drug and alcohol intoxication. There's a mnemonic for remembering the various conditions that can result in altered mental status, AEIOU tips. If you've never seen that before, this is commonly taught now in EMT and paramedic schools, and it's included in most textbooks. And that's just a sampling of some of the conditions that can mimic psychiatric disorders. The difference is these things appear suddenly for the most part. Uremia and infection there, you think of sepsis, and if you've never had the pleasure of having a patient with a pretty bad case of a urinary tract infection, I can tell you that when I first began working in EMS, one of the most bizarre and what I thought to be crazy patients that I had ever had or have had since, my partner, who had been in the field for over 30 years, commented, "I'll bet this is a UTI." I was like, "What are you talking about?" That I didn't say anything, but I just went along with it. Well, sure enough, it turned out that there was a urinary tract infection. And you think about it, the underlying toxins and different things that are not being flushed from the body system, they are circulating through the blood and into the brain and having all kinds of chemical effects and reactions. So those are just some things to rule out, have in the back of your mind when we're coming up with our differential diagnoses. So now we're going to move on to true psychiatric illness. There are literally hundreds of classifications, but we're not going to have that much time, obviously. So we're going to key in on two disorders in particular that are especially known for a potential for psychotic behavior. And this first one here is schizophrenia. It's actually a group of disorders. It's characterized by recurrent episodes of psychotic behavior, which may include abnormalities in thought process, thought content, the patient's perceptions, and their judgment. So there are two categories of symptoms with schizophrenia. There's the positive symptoms, which are the most dramatic and obvious, eye-catching of all of the features. And these would include things like hallucinations and delusions. Hallucinations can be visual or auditory, and to a lesser extent, you could have olfactory or kinesthetic hallucinations as well, where someone smells or feels something that's not actually there. And about 90% of all schizophrenics have experienced hallucinations at one time or another. And then you have delusions. These are false beliefs, believing something to be true when it is entirely false. And these commonly, you've probably heard of someone having delusions of grandeur, meaning they may think that they are especially important, or they may think themselves to have magical powers. They may even believe themselves to be a deity. You know, you've heard someone maybe perhaps claim to be God himself. There are delusions of persecution, where the person feels that they are being unfairly singled out, like people are out to get them. And that goes right along with paranoia, which sometimes manifests with schizophrenia. There are delusions of thought broadcasting and thought insertion. And what that means, thought broadcasting, these are the folks that believe that other people have the ability to read their thoughts. So you think of the comical patient with the tinfoil hat. That could be an example, a visual example of someone experiencing the delusion of thought broadcasting, or thought insertion, which is where the person believes that other people are able to insert thoughts into their mind. And the list goes on and on. Another feature that's not listed here on the screen is flight of ideas. This is a rapid shifting of thoughts that have very little, if any, connection between one sentence to the next. So they appear to be rambling from subject to subject. And that's not just a typical symptom with schizophrenia. It's also present in the manic phase of bipolar disorder, which we'll talk about momentarily. And you can even have it go one step further to word salad. It's kind of an unofficial way to refer to this, where in what is supposed to be a single sentence may have 5 or 6 completely unrelated words that make no sense whatsoever. And that's just some of the things that you could see with the positive symptoms. Now, negative symptoms, these aren't as eye-catching. They're not as dramatic, but they tend to last longer than the positive symptoms, and they are much more difficult to treat. Negative symptoms represent a reduction in emotional responsiveness, motivation, their socialization skills, their speech could be slowed down, even their movement can appear to be slowed. Flat affect is common with this type of presentation, these symptoms, or you may have heard it referred to as a blunted affect, which is a lack of normal feelings and behaviors. They don't seem happy, they don't seem sad, they don't seem angry, they just seem flat, monotone, robotic in mood, like completely devoid of emotion. Or there's another thing that's called poverty of thought, where the patient appears to be devoid of thought whatsoever, or seems to have a feeling of emptiness inside. Now, the good news is that the current psychiatric medications tend to be very effective for those positive symptoms of schizophrenia, but less so when it comes to the negative symptoms. We'll talk more about the medications here in a moment. But first, I want to show you a video of this gentleman by the name of Gerald. Gerald is a schizophrenic who displays almost every sign, positive symptoms.
Milligrams daily.
I'm doing so hot. I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in.
Is this a new feeling for you?
The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
Must be very frightening for you, though. Feel like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache?
You want to know?
Yes, I do.
Okay, when a sperm and an egg go together to make a baby, only one sperm goes up in the egg. And when they touch, there's 2 contact points that touch before any other 2. And then it's carried up into the egg. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the proton. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to 1 atom.
Jerry, in one patient at one time, shows almost every one of the major features of schizophrenia. His thinking is disorganized. The thoughts are loosely connected. He has formed delusional ideas. Some of those delusions are grandiose. Some of them are paranoid. He has disturbances in his mood. His mood is, in some cases, almost absent, and in other cases is totally inappropriate. And his behavior is disordered. It's unusual. He has mannerisms that are inexplicable. He has purposeless, aimless behavior around the ward. He's a textbook case.
So you can imagine trying to communicate with someone like Gerald, trying to ask questions as part of your assessment could be very challenging. We'll talk more about the communication barriers and how to overcome some of those here in a moment. But first, I want to speak to this common question of nature versus nurture. In other words, is schizophrenia, is that purely the result of the way the person was raised or some sort of trauma that they experienced in life, not physical trauma, but emotional trauma? Or is it truly biological in origin, genetic, for example? Now, the chart that you're looking at here is an example of a twin study where, in this case, an adoption study where they've taken a pair of identical twins who were put up for adoption at birth and separated, sent to live in maybe different parts of the country, but definitely different environments, different families, different experiences in life. And yet, despite those differences, if one of the twins develops schizophrenia, the other has about a 50% chance of also developing the disorder. So there is definitely a strong biological component. It's thought that sometimes environmental stress, traumatic life events may trigger the onset, but the predisposition is biologically there regardless of what the individual does. The onset tends to be most apparent around late adolescence or early adulthood. And as I alluded a moment ago, many schizophrenic patients can function quite well as long as they are put on the right medication. Others don't fare so well. They function poorly between their psychotic episodes, often due to medication non-compliance. So for whatever reason, they just stop taking their meds. Now, what would you say are some common reasons for that non-compliance? Some of the most common that come to my mind are a lack of money. They don't have the financial stability to afford the medicines. Maybe they don't have health insurance. Maybe they lack a good support system, a family around them, for example, that's there to keep them accountable for taking those meds. And a number of these folks can fall through the cracks because of that lack of a support system. But there's another reason for non-compliance, and that is the side effects of many of these medicines. Now, I want to stress that these side effects are more typical of what are referred to as the first generation or classic antipsychotic medications. So some of the older ones, but now a number of these are still used for various reasons. But they are more likely than the new second generation antipsychotics. The classic first generation antipsychotics are more likely to produce this particular list of side effects. It's the quintessential, the cure is worse than the disease for some patients. Acute dystonia, which is uncontrolled movements of the face, neck, and tongue. Oculomotor crisis, again, this is an uncontrollable movement, in this case of the eyes. Akathisia, which is restlessness and agitation. These patients can even have symptoms that mimic Parkinson's disease, with slowed movement, a shuffling gait, facial tremors, and so on. One of the more recognized among all of these side effects is termed tardive dyskinesia. And what you'll notice is that there is this quivering of the lips, the mouth. In some patients, you can have what they refer to as tongue thrusting, where their tongue just periodically just starts protruding between the lips. Is a movement disorder that can develop months, years, even decades after the patient has begun taking the antipsychotics. Now, the best and most effective treatment is prevention. Never to get it in the first place. But that's difficult to predict with some patients. There are some risk factors, such as older age, being on the medication longer, alcoholism, substance abuse, and for whatever reason, females, African Americans, Asian Americans are at greater risk. But regardless, sometimes a patient can be on one of these antipsychotic medications, and then for whatever reason they're switched to a different one. Maybe they're going from a first generation to a second generation medication. But even years after stopping that first medicine, they could all of a sudden present with tardive dyskinesia as a long-term effect, which is difficult and in some cases virtually impossible to reverse.
Bipolar depression, manic depression, these are terms that are all meaning the same thing. The manic part of it, think of that as the highest of highs in your life. You feel great, you may be more reckless though. The depressed part of it is sort of the lowest of the lows. I want to try and simplify this for you because I find this really fascinating. Here are the frontal lobes of the brain, and deep in here is an area of the brain called the amygdala. Think of the frontal lobes of the brain as your judgment area of the brain, but also your brakes. The area of the brain that tells you to slow down, to stop, think a little bit before you do something. And think of the amygdala as the emotional center in the brain. So someone who is manic typically has no brakes, frontal lobes are not really active, and the amygdala is red hot, meaning it's super active. Things that you think, you immediately do. It may lead to wild bursts of creativity with unlimited energy. That's oftentimes what the manic phase is. Depression, think about it as exactly the opposite. The frontal lobes are now turned all the way up. That means everything is just stopped. Nothing's getting out. The amygdala turned down. It means you have just no emotion. So you're apathetic, you don't want to get out of the house, you simply don't want to do anything. That's what's happening in the brain of someone who has manic depression. The episodes can last hours, they can last days, they can last weeks. People can go through cycles over a time. So within a year, you could have 4 cycles from mania to depression and so forth. Typically, people really start to develop symptoms in their late teens and early 20s. About half of people are diagnosed before the age of 25. Many people can get good treatment for bipolar depression, but I think it's fair to say that it's not easy. First of all, it can be challenging to get the diagnosis. Second of all, it can be challenging to trial medications, see if they're working. But the key is ultimately finding a medication that's more of a mood stabilizer. You don't want to give someone an antidepressant who could possibly go into a manic phase. That could just worsen the mania. It's more about giving mood stabilizations to cut down on the intensity of the mania and the depression.
When I'm manic, I'm very agitated because what I find is that I have so many things going on in my head that I really can't actually do anything. This is when I'm in a very elevated state. And so it's very frustrating for me. When I'm really manic, because it can become very dangerous for me, I call my doctor right away, and I'll do a walk-in and talk with her because I can become quite delusional. Stress affects me a great deal, so much so that I can't work, and I will never be able to work again because when I work, I go instantly into a mania and end up in the hospital. So I have to really be careful with stress, keep my stress level down, and this isn't just with negative stress, it's with positive stress as well. So I have to keep a schedule of things that I do during the week to keep myself occupied and make sure I don't go off the deep end in any particular direction. When I'm hypomanic, I find that, I'm just really happy, joy. I could do anything in the world, and I generally do. I exercise a lot, and I get a lot of stuff done around the house, and I'm online, and I forget that I have any problems at all. The tendency towards spending is a risk for me, so I always have to watch that, and it's something I pay attention to. a lot because suddenly all my financial difficulties or anything are just right out the window. And it's like, oh, I could buy this and I could buy that. Sure, why not? It'll all work out at the end. I rather enjoy it. So I have to admit that. I have to keep an eye on it because I also am very aware of the fact that the longer the hypomania lasts, the longer the depression is going to last afterwards. When oh my goodness, I'm depressed now, actually. And it's really hard for me to motivate to do anything. Really all I want to do is just curl up on the couch and just isolate from the world and avoid people. I find that the deeper my depression gets, the less I want to do. For instance, I love to exercise, and I find that I don't even exercise anymore. So I'll just sit at home and do my hobbies and try to avoid people at all costs. The irritation, my irritability, impatience with people, my lack of motivation to do things, even, you know, just straighten up around the house. If I look around and I see things are just becoming in disarray, that clues me in.
When someone is in the manic phase, it is often the case that hospitalization is absolutely required for the sake of getting the patient's symptoms under control, and oftentimes getting them back on their medication regimen, because during that hypomanic and especially the manic phase, they can lose the sense that that medication is doing anything for them. They may feel so good that they say, well, I don't need this medication anymore, and they just stop taking it. When someone's in the manic phase, that is the phase where bipolar patients are more likely to have interactions with police, crisis intervention. Now, all of this is generally speaking. There are definitely exceptions to the rules. These things are just kind of more common than not, I guess you could say. The manic phase can range from anything like euphoria to delirium, all the way up to psychosis, where they're having delusions, much like a schizophrenic. One thing that Alex said in her video, she mentioned that spending is a risk for her. Spree spending is relatively common for folks in that hypomanic or manic phase. In fact, in some patients, there have been entire fortunes spent in that phase. They're also more likely to engage in reckless, dangerous behavior, sexual indiscrimination. And if it's left completely untreated, a manic episode could last anywhere between 3 and 6 months. Some patients turn to substance abuse as a form of self-medication. And the hypomanic phase is very much the same, similar as a manic phase, except that it's a milder form and it does not produce the psychotic features, and it doesn't decrease the individual's ability to function in daily life. For some, they just feel really good. I mean, Alex said that she really enjoyed it. But it is problematic because they tend to forget the effects that their behavior has on the people around them. And oftentimes their family and their friends may notice that something has changed and they're noticing the mood swings, but the patient will maybe become irate when they say something about it and deny that anything's wrong at all. The depression is very much just like what you'd think, depression. The risk of suicide is increased, as is the risk of self-harm, like cutting themselves, not for the purpose of killing themselves, but for whatever reason. The self-harm occurs in up to 30 to 40% of patients with bipolar disorder. The medications, as long as a patient is on these medications, it tends to be highly effective for the most case. In about 70% of cases, lithium is effective. Others may need Tegretol along with the lithium, or Depakote. You've probably come across those. And mood stabilizers like lamotrigine is another example.